Wrapping up today with Chapter 69, Arthritis and Connective Tissue Diseases. Due to the length, I've split this up into Part 1 and Part 2. Let's start with osteoarthritis. This is a slowly progressive, non-inflammatory disorder of the diarthroidal synovial joints. Up to 30 million U.S. adults are affected, with the numbers expected to increase as the population continues to age and get older and older demographically. More common in women, especially in the hands and knees. Most men not affected as often as women until 70 to 80 years, except for traumatic arthritis. Also in cases of guys that have worked a lot of very strenuous manual labor over their lifetimes. In that case, hip osteoarthritis is the most common. In our first case study, AL, a 47-year-old man, presents to a clinic with pain in his right knee with activity. He has a negative history for illnesses or trauma. He used to play soccer regularly, but he has not played in 10 years. He says the pain prevents him from playing football with his teenage son. The healthcare provider suspects osteoarthritis. In preparation for teaching the patient about this disease process, you decide to quickly review its etiology and pathophysiology. So what exactly is this osteoarthritis that's causing the pain in his right knee? Osteoarthritis is that wearing down of that cartilage cushion that sits in between where two bones meet. And as that cartilage cushion wears down, that patient's bones then begin grinding on themselves. And as soon as those bones begin touching and grinding, that's going to be the source of our osteoarthritis. In this case, our patient was a longtime soccer player, and that years of playing soccer has worn down the cartilage within his knee to where bone is now touching, and it's now painful and impacting him later in life. Osteoarthritis is characterized by that gradual loss of articular cartilage, that cartilage within the joints, and also the formation of osteophytes in the joint margins, and this is that worn down, discarded tissue building up on the edges. It is not part of the aging process. Cartilage destruction begins between ages 20 and 30. Most adults affected by age 40. Symptoms manifest after age 50, and more than 50% over the age 65 report having arthritis. Secondary arthritis, on the other hand, is caused by direct damage or joint instability, where we've now had some sort of injury, and now that joint just is not sitting and moving exactly the way it was designed to, which is greatly increasing its rate of wearing down. Idiopathic osteoarthritis. This is an event or condition that may not be known. Genetics may contribute. It could also be secondary to some sort of infection. Risk factors: age, decreased estrogen at menopause, obesity, anterior cruciate ligament injuries, frequent kneeling or stooping, and regular moderate exercise will decrease this risk. As with many factors of aging, there's a complex interaction of genetic, metabolic, and local factors that lead to the development of osteoarthritis. The destruction of that articular cartilage causes narrowing in the joint space. The cartilage becomes dull, yellow, granular, softer and less elastic, and less able to resist that wear of heavy use. And as it ages and begins wearing down much quicker, we start getting that bone-on-bone contact. The articular surface is cracked and worn down. The inflammation and thickening of that capsule in the synovium causes early-stage pain and stiffness. Central cartilage is thinner, edges become thicker, and osteophytes are formed, resulting in an uneven weight distribution. Bones rub together, leading to increased pain in later stages. Joint pain is going to be that hallmark sign. It's that primary symptom ranging from mild discomfort to significant disability. And this pain is going to worsen. As the early stages, it will be relieved with rest. But as it slowly progresses, that pain with rest and trouble sleeping due to increased pain. And the pain may worsen with lower barometric pressures as well. Have you ever heard somebody, that cliche, that old guy, he can tell it's going to rain, he can feel it in his knee? Well, that's what he's talking about. He can feel the pressure changes in his injured arthritic knee. Pain contributes to disability and loss of function as that osteoarthritis progresses. Pain may be referred to groin, buttock, or outside of thigh and knee. Sitting down becomes difficult, as does getting up from a chair when hips are lower than knees. Osteoarthritis in intervertebral joints causes local pain and stiffness. Joint stiffness occurs after periods of rest or unchanged position. Early morning stiffness usually resolves within 30 minutes, and this distinguishes it from rheumatoid arthritis, which we'll get in here in later slides. Overactivity leads to mild joint effusion, temporarily increasing stiffness, causing that crepitation. Again, that crepitation is just that grinding sound of the bone rubbing on bone. And osteoarthritis also affects the joints asymmetrically, causing them to be slightly off-center or disfigured. Here on diagram 69.2 from your text, we have a chart that's showing the most common areas affected by arthritis. Everything from the hips, knees, the phalanges, and cervical and lumbar vertebrae of the spine. There's going to be many different deformities you'll see with arthritis. Everything from Heberden and Bouchard nodes, and these are the swelling of the joints within the hands. A Heberden node would be in that upper joint, whereas a Bouchard is going to be down in the middle joint of the finger. Vagus deformities, including bow-legged or knock-kneed, with one leg shorter than the other in the case of deformities of the hip. Here's a picture of those Heberden nodes, up there in the distal joint of the finger, where if they were down in the middle joint of the finger, they would be called Bouchard's nodes. We could also have, in our case, systemic arthritis, and this would be secondary to some sort of infection, even though fatigue, fever, and organ involvement are not necessarily involved. And it distinguishes osteoarthritis from other inflammatory disorders, such as rheumatoid arthritis. Upon examination of the patient's knee, there's no swelling noted, but crepitation is present. What diagnostic studies would you expect the healthcare provider to order? In this case, you're going to expect some sort of imaging as your first course. Bone scan, CT scan, MRIs, X-rays. While there's no specific lab tests or biomarkers for arthritis, baseline labs may be done before starting for screening for secondary conditions that may be contributing to it. The healthcare provider orders an X-ray and an MRI of AL's knee. The results showed joint space narrowing and osteophyte formation. What treatment would you expect the healthcare provider to order? Unfortunately, there's not necessarily a cure for arthritis. There's not a lot we can do to bring that joint cartilage back. Managing the pain and inflammation is going to be key, helping to prevent that disability, slow its progression. Maybe some drug therapies we could do, corticosteroids, things to lower the inflammation, help to mitigate and manage the pain. NSAIDs is going to be a very common over-the-counter medication for this patient. Again, these drugs are thought to slow the progression of osteoarthritis or support joint healing. And unfortunately, to date, there's no drugs that have been approved despite research. There's nothing that's really going to cure that arthritis. We can only slow its progression. And again, NSAIDs, topical agents, anything we can do to help relieve that pain and swelling within that patient's joint. Oral NSAID therapy. We know what NSAIDs are, ibuprofen. And remember, we want to start low and increase if necessary. People think of ibuprofen, Motrin, even Tylenol in a different class as these benign substances because they're over the counter. And they're really not. We really want to be careful with those. In the case of NSAIDs, they're severely nephrotoxic. And we do not want these patients on more than they need. Other things, COX-2 inhibitors, Celebrex. Aspirin is no longer a common treatment for this. And response to and costs of NSAIDs may vary. If our previous treatments were unsuccessful, we may move up to intra-articular corticosteroid injections. This is going to be that next step up, though if 4 more injections without relief suggests we're going to need to try a different intervention. Systemic corticosteroids may even hasten the disease process eventually. While it's effective in the short term, in the long run, we're actually increasing the rate that cartilage is being broken down. And if none of those interventions were successful, we may move up to surgery. The symptoms of arthritis may be managed conservatively for many years until we're finally at a point where we're going to need a hip or knee replacement. That surgery is considered for complete loss of joint function, unmanaged pain, and increased dependence on that self-care where they are losing function, they are losing mobility. Other complementary and alternative therapies, acupuncture, massage, tai chi, a lot of nutritional supplements such as fish oil, ginger, glucosamine, and chondroitin. And any supplements or therapies, again, make sure that these are documented within your patient's chart. Make sure that the provider who's writing their prescriptions knows when a patient is on these complementary and alternative therapies. We don't want to discourage the patient from seeking alternative therapies, but we want to make sure it's documented. Make sure everybody is on the same page for exactly what that patient is taking. Wrapping up our case study, the healthcare provider orders NSAIDs and rest for the patient during periods of acute inflammation, but not longer than 1 week. The patient asks you about other treatment strategies. How would you respond? And again, letting the patient know that there are wide courses of action. Know of our goals here. It's to rest, reduce that inflammation, and minimize and manage pain wherever possible. We don't want to necessarily go up to more invasive treatments, but at the same time, we want to make sure the patient's on the same page, knows what we're ordering, why we're ordering it, and the reason for our current treatments. There's going to be many factors that guide our course of treatment. It's going to depend on the joint pain, its type, location, severity, frequency and duration, and any aggravating and relieving factors. How much is this pain affecting the patient's daily life? And we want to assess the effective joints for tenderness, swelling, limitation of movement, or listening and feeling for that crepitation. Again, managing that pain is going to be our priority for arthritis. We want to maintain or improve that joint function through balance, rest, and activity, using joint protection measures to improve that activity tolerance, and maintaining that independence, keeping them as functional and mobile as possible. Other lifestyle changes could also be very beneficial for slowing that progression. Losing weight, which, just as it sounds, the more weight you're putting on those hips and knees, the faster they're going to wear down. We also want to reduce those occupational and recreational hazards wherever possible. Can we just tell the patient to get another job? No, probably not. But at the same time, looking at proper lifting strategies, looking at anything we can do to reduce the wear and strain on those joints. Other athletic instruction and physical programs to include safety measures, braces to protect those joints, and reducing the trauma on those joints. Ambulatory care and outpatient treatments is going to be a big part of the care of arthritis. It's going to be a very severe case where they're in the hospital with a sort of surgical treatments and very, very severe cases of arthritis. For that outpatient treatment, we're going to see physicians and providers along with rheumatologists, nurses. OT and PT could play a very big role in their care. And also for us as nurses, always be providing that education on the nature of the treatment, pain management, correct body mechanics and use of assistive devices, and everything we can do collaboratively to lessen this patient's symptoms. Another great at-home treatment for these patients is going to be heat and cold applications. Ice to help to reduce that swelling during acute inflammation. And on the other hand, heat's useful for increasing the flexibility, increasing the blood flow to the area. Hot packs, whirlpool baths, ultrasound, and paraffin wax baths. It's going to be dependent on this patient's symptoms. If it's originating from inflammation and swelling, we're going to go to ice. If it's dealing with stiffness, we're going to use heat to help loosen that joint. You're going to see this subject come up again and again through our med-surg course here, and that's weight reduction. Again, dietary changes as needed. Obesity's been a major problem for a long time, and it's only continuing to grow, especially in this country. We also want to be improving their exercises. Finding out what exercises they enjoy, what exercises they're capable of performing themselves. Everything from aerobic conditioning, range of motion, muscle strengthening around that affected joint, and balance exercises. And don't dismiss PT and OT. PT and OT can be very, very effective in improving that patient's functioning as well. Keep in mind, when recommending exercises, we're not trying to wear these patients out. We want to balance rest with activity. Rest during those acute inflammation stages. Modify activities to decrease joint stress. Avoid prolonged standing, kneeling, squatting, and recommending assistive devices wherever needed and necessary. Adjust the home management goals. Include the family members, include their spouse, their caregivers, significant others. And also think about that home and work environment. Anything we can do to keep that patient moving around as much as possible. Eliminating those scatter rugs, using railings and nightlights, wearing well-fitted supporting shoes, assistive devices, canes, walkers, elevated toilet seats, putting those grab bars in the showers, identifying potential safety. If they're having significant arthritis, especially in the knees and hips, falls, balance, and dangers, preventing those falls and other dangers is going to be a key role of you as a nurse. Because again, that's also what NCLEX is testing you on. We have met all those patients' physiologic needs. Now, what is the major danger this patient is in? Our expected outcomes: have adequate rest and activity, achieve acceptable pain management, and maintain that joint flexibility and muscle strength through joint protection, therapeutic exercise, every intervention we could possibly do, and a multitude of different interventions combined together to improve this patient's quality of life. An often confused and used interchangeably but very different condition is rheumatoid arthritis. Rheumatoid arthritis is a chronic systemic autoimmune disease resulting in inflammation of connective tissue and diarthroidal synovial joints. It results in periods of readmission and exacerbation, extra-articular manifestations, disabling form of arthritis causing loss of independence and self-care. Mobility aids or joint reconstruction may be needed if treatment's inadequate, and the symptoms and outcomes may vary greatly. Rheumatoid arthritis is a problem globally, and it affects all ethnic groups. It can occur at any time of life, most often beginning in females between ages of 30 and 60. Men rare less than 45 years, and affects about 1.5 million U.S. adults. Almost 3 times as many women have RA as men. For our rheumatoid case study, TS is a 40-year-old woman who presents to the clinic with fatigue, morning stiffness, and painful swelling in her fingers. The healthcare provider suspects rheumatoid arthritis. In preparation for teaching TS about this disease process, you decide to quickly review its etiology and pathophysiology. What causes RA? And describe the pathophysiology. And again, just as we discussed, it's often a genetic component. Females are much more predisposed to developing this condition. And its pathophysiology is going to be an inflammatory form of arthritis, as we'll get into more. The exact cause of rheumatoid is unknown. It has an autoimmune etiology with a combination of genetics and environmental factors. Antigen triggers the formation of abnormal immunoglobulins, and the body is actually attacking its own cartilage, causing this inflammation. The rheumatoid factor, RF, combines with IgG to form immune complexes that deposit on those synovial membranes or cartilage within the joints, and this leads to the activation of complement and inflammatory responses. In a very real sense, the body is attacking its own joints. T helper cells, CD4, are activated, stimulating monocytes, macrophages, and synovial fibroblasts to secrete pro-inflammatory cytokines. A diagram in 69.3 from your text, just breaking down the pathophysiology of rheumatoid. In figure A here in the top left is an early pathologic change is rheumatoid synovitis. That synovium becomes inflamed, lymphocytes and plasma cells increase greatly. In figure B in the top right, over time articular cartilage destruction occurs, and vascular granulation, tissue, grows within that cartilage surface. From the edges of the joint surface shows a loss of cartilage beneath the extending pannus, most marked at the joint margins. In figure C in the bottom left, inflammatory pannus causes focal destruction of that bone. Osteolytic destruction of the bone occurs at the joint edges, causing the erosion seen on x-rays. This phase is associated with that joint deformity where it's swelling and begins to drift to side, and you can see a good example of that rheumatoid deformity in the feet in figure D there at the bottom right. Again, that exact cause of rheumatoid is unknown, and it could be a wide variety of factors. Some patients report precipitating stressful event. Others a genetic link. That genetic predisposition is important in RA development, as it often runs in families. Also, smoking increases the risk in patients genetically predisposed and may interfere with that treatment. The onset is often slow and subtle, starting with fatigue, anorexia, weight loss, generalized stiffness that becomes localized stiffness with progression, and the specific joint involvement, pain, stiffness, limited motion, and signs of inflammation. Signs occur symmetrically and often affect the small joints in those phalanges and tarsals, and larger joints and cervical spine may begin to be involved as it progresses. Other signs are going to be joint stiffness after inactivity, morning stiffness 60 minutes to several hours or longer, fingers spindle-shaped in early disease, with the joints tender, painful, warm to touch, and the pain increases with motion, intensity varies, and may not be related to the degree of inflammation. Tenosynovitis could affect the wrist, and with progression, inflammation and fibrosis may cause deformity and disability. We could also get what's called subluxation and muscle atrophy and tendon destruction, walking disabilities, and finally deformities in the hands such as ulnar drift, swan neck, and boutonniere's deformity, which we have diagrams of here on the next slide. Here in Figure A on the top left of our screen, we've got ulnar drift of those fingers all drifting to one side. In Figure B, we've got boutonniere's disease, boutonniere deformity. In Figure C, in the bottom left, we've got that hallux valgus, and that is affecting the toes, causing that drift. And in Figure D, we've got a swan neck deformity. And a very common question you see, especially in ATI, is having you differentiate between B, boutonniere's deformity, and D, swan neck deformity, because they are so similar but different. Keep in mind with that Figure D, that swan neck, this upper finger is going forward, creating the swan's face. Not sure if that's showing up. I kind of can't do my finger like that. But yeah, make sure you're really good at those different deformities, especially with B, boutonnieres, and D, swan necks. These extra-articular manifestations can affect every part of the body, more likely in people with high levels of biomarkers. Atherosclerosis, chronic inflammation that damages those endothelial cells within the blood vessels. More cholesterol plaques form, leading to heart attacks, strokes when they break loose, and the risk of heart attack is 60% higher than people without RA. Another major concern will be these rheumatoid nodules. They develop in about 50% of patients with RA. They're firm, non-tender masses found on the bony areas exposed to pressure, fingers, elbows, and the treatment's not usually needed. Watch for skin breakdown like pressure injuries, and they may even form in the lungs, though usually harmless. Another symptom you're going to see come up, a condition that goes along with a lot of the different rheumatoid conditions we're going to talk about today, is Sjogren's syndrome. And this is an autoimmune disease where it's actually damaging the tear glands, the lacrimal glands, and the salivary glands. And it goes along with a lot of the autoimmune conditions, where when they have an autoimmune condition such as rheumatoid that's attacking the joints, it's also often damaging those salivary and lacrimal glands. For Sjogren's, it's that damage to the tear production glands, causing dry, gritty eyes, photosensitivity, and may need to treat that dryness to prevent damage to the eyes. Also, Felty syndrome. This is an enlarged spleen and low white blood cells. Rare but more common in those with long-standing rheumatoid arthritis. Affecting their mobility, they may have flexion contractures and hand deformities, decreasing the grasp strength, decreasing their ability for self-care, decreasing their ability to do many of the activities you take for granted day to day. Going along with this could also be depression, pain, and disability. And, as they're in severe pain, they're less able to do the things that they once enjoyed. They will slowly develop depression. And we never want to discount those psychosocial considerations going along with their chronic conditions. When assessing rheumatoid, there's a lot of different diagnostic studies we're going to need to look at. Everything from that history and physical findings to the criteria of joint involvement and lab tests used to confirm that diagnosis, serology, acute phase reactants, and the duration of their symptoms. Positive RF occurs in about 80% of adults with RA. And while it does not guarantee a diagnosis, negative RF does not exclude the disease either. Other studies, a synovial fluid analysis, a cloudy straw-colored fluid with fibrin necks, white blood cells, and we can also do a tissue biopsy to confirm early inflammatory changes. An X-ray alone is not a diagnosis of RA, though that imaging could show the inflammation and breakdown that we could be expecting with the disease. Bone scans are more useful in detecting those early changes. Rheumatoid is a condition of slow progression. In stage 1, you have that synovitis, with an X-ray showing the soft tissue swelling with possible osteoporosis, though no joint destruction present. Following up with stage 2, we've got that increased joint inflammation, a gradual destruction of that joint cartilage, and a narrowing of the joint space from the loss of that cartilage. In stage 3, we have the formation of synovial pannus, and an x-ray would show the extensive cartilage loss, erosion at the joint margins, and possibly even a deformity. And then finally, at stage 4, we have that inflammatory process subsiding with a loss of joint function and the formation of subcutaneous nodules. Going back to our case study, the result of TS's hand x-rays showed no significant abnormality. In what stage would you expect his RA to be classified? And in these early stages, that's going to be a stage 1 most likely. The patient's lab results indicate positive RF and anti-nuclear antibodies. Her CRP and ESR are also elevated. The healthcare provider tells TS she has rheumatoid arthritis. What medications would you expect the provider to prescribe for them? In this case, most likely something like methotrexate in combination with an NSAID. In this way, we can both lower the immune system attacking those joints, as well as lowering that inflammation to slow the wear, tear, destruction, along with the pain. The treatment plan for rheumatoid arthritis, it's going to vary greatly on each individual patient. Everything from the disease activity, the level of joint function and disability, their age, sex, and response to previous treatments. As the treatment advances, they have improved prognosis. It's very aggressive in that early treatment to catch it early and hopefully stop it before it can progress into those later forms of the disease. Drugs are a cornerstone of treatment for the case of rheumatoid arthritis, but unfortunately they can also cause irreversible changes that can occur in that first year. Healthcare providers aggressively prescribing disease-modifying anti-rheumatic drugs. They're used to slow the disease progression and decrease the risk of joint deformity and erosion, and of that rheumatoid progressing to a level that could greatly affect that patient down the road, causing deformities, causing pain, causing severe disability. But at the same time, these are very invasive drugs that can be very hard on the body as well. Methotrexate is going to be your most common. It's used in the early treatment, has lower toxicity, though the side effects are bone marrow suppression and hepatotoxicity. We need to be monitoring those CBCs and blood chemistry, and the therapeutic effects of this drug can take 4 to 6 weeks and may be given alone or with biologic response modifiers. Other options would be azulfidine or Plaquenil, and these are used for mild to moderate disease. Rapidly absorbed, relatively safe, and well tolerated. You may recognize hydroxychloroquine as one of those early drug recommendations from back in COVID. This is actually one of those wonder drugs that was created originally for the treatment of malaria that now gets used in a wide range of applications. You could also see biologic response modifiers used, also called biologics or immunotherapy. They slow the progression and used alone or in combination with other drugs. And they're used to treat that moderate to severe disease. And these are going to be used for much later. This is not going to be our first course of treatment. Not to get too deep, because these biologic response modifiers, we could do an entire day on these. But know that they're classified based on the mechanism of action, and all work to inhibit that inflammatory response. Major considerations. One's going to be a TB test and chest x-ray before the start of the therapy. Because if this patient has an unknown latent tuberculosis and we start minimizing their immune function, that TB could rapidly develop into an active form of the disease. We're going to monitor for infections, notify the healthcare provider if any acute infection occurs after beginning the drug. We're also going to avoid live vaccinations for 4 weeks before starting. Other drug therapies that could be used, antibiotics such as doxycycline, though not FDA approved for the treatment of RA, could be rarely used immunosuppressants, and even thinking back to our OAs module, those corticosteroids and intra-articular injections to treat the arthritis itself. You're going to see NSAIDs come up a lot in the case of both osteoarthritis and rheumatoid arthritis, just from how effective they are at both treating the pain and the inflammation. Unfortunately, they do not delay the progression of rheumatoid, but they do greatly help manage those symptoms. It may take 2 to 3 weeks for full effectiveness. And again, that Celebrex, that COX-2 inhibitor, is going to be another one you see come up a lot. In severe cases, you may see surgical therapy also recommended, everything on up to that total joint replacement. And this is going to be in the case of relieving severe deformity and pain. We're going to be focusing both on subjective and objective data. Both our physical assessment, what we can see the results of this disease are, and also the subjective assessment, the reported pain, the reported disability this patient is feeling and how it is affecting their lives. Because again, our major concerns are going to be that impaired musculoskeletal function, their mobility, and how much pain they are feeling throughout their day. Because when you start getting into rheumatoid, this is a very, very painful condition. These patients are often in very chronic pain, and we want to do everything we can to both identify and minimize that pain. Our overall goals are going to be acceptable pain management, the minimal loss of function of these affected joints, helping them take part in planning and implementing the treatment plan. Remember, that patient is always an active participant in their care. We want to maintain that positive self-image, report self-care to a maximum amount possible, help this patient care for themselves as much as they can. Just like with every other condition, it's going to be a wide range of interventions working together. Drug therapy combined with self-management strategies, exercises, both therapeutic heat and cold, rest, relaxation techniques, and identify which strategies are most effective for this patient. Most of the care is going to be outpatient, hospitalized for systemic complications or surgery, and working with the provider to regain function, adjust to that chronic illness, and helping to slow the progression of that disease. Because again, in many, many cases, much of this symptoms is going to be irreversible, but we can slow the progression. Energy conservation would be a major consideration with this as well. Remember, these patients are both living with limited mobility, decreased function, as well as pain, and moving and managing this can be extremely taxing. We want to make sure these patients are getting 8 to 10 hours of sleep, plus rest throughout the daytime. We want to modify activities to avoid their overexertion. We want to keep them moving. We want them doing as much as possible, but we do not want to wear them out either. An often overlooked consideration is going to be good alignment during rest. We want a firm mattress or bedboard. Encourage positions of extension where they're stretched out. We don't want flexion positions. We don't want them in a flexed position. We don't want knees under the pillows, and this will help decrease our risk for contractures forming. We also want to modify tasks, both to improve their self-care, what they're capable of performing themselves, but also to provide that less stress on the joints. Using carts, providing convenient, easy-to-reach storages, lower shelves, joint protective devices, and getting that occupational therapy involved as well. Help maintain upper extremity function. Coming back again to cold and heat therapy to relieve that pain, stiffness, and muscle spasms. Cold especially is beneficial during periods of increased disease activity. Though the application should not exceed 10 to 15 minutes, we could get the special cold packs online or from Walgreens, or we could also use bags of frozen vegetables. On the other side, moist heat, used to relieve that chronic stiffness. Should not exceed 20 minutes a time. And again, everything from heating pads, moist heat packs, paraffin baths, warm baths. Do not use topical heat-producing cream, and be alert for that burn potential, especially in the cases of decreased sensitivity, diabetes, neuropathies. Burns is going to be a major, major danger when you start talking about these external heat, especially in the form of heating pads. Also including exercise within that treatment plan. Improved flexibility and strength, increased overall endurance. Encourage that program participation, and reinforce correct performance. And again, another one I see come up on ATI and NCLEX a lot is asking that patient which activities they enjoy. That's going to go a long way in keeping that patient involved. What sports, which physical activities? Do they enjoy walking? Do they enjoy tennis in cases where they still have high levels of mobility? And finding out what they enjoy and what they're going to be most compliant with. Also, daily gentle range of motion exercises to keep those joints functional, to keep those joints with full movement. Practice with supervision. You could also consider aquatic exercises in warm water. Two-way resistance makes that muscles work harder than on land. Nutrition will play another key role in the treatment of this disease. We want to minimize the weight loss coming secondary from the pain, fatigue, depression. and helping the patient with everything from food shopping, assessing what they're able to cook themselves, and making sure that they're able to cook their own meals, or make sure that they're able to have balanced, healthy nutrition prepared for them. Another thing to be aware of is going to be the weight gain secondary to the corticosteroid therapy. Keep in mind, remind the patient that the weight will return to normal several months after after that treatment ends. Though in the case of especially females, we want to make sure they're aware of the reason we're on this medication, ways to minimize that weight gain. And that's going to go a long way because especially when they start gaining weight taking it, they may just stop taking it entirely. We also want to evaluate that their support system. Are they living alone? Do they have a spouse who is active in their treatment? Do they have children or other family members close by that can come and help them? We want to also consider community resources, home care, vocational rehab, and self-help groups can all go a long way in helping the patient manage this disease. Also be aware of patient vulnerability. They're going to be very scared as this condition begins to develop. Make sure they're aware of the false remedies, especially for chronic pain. There are a lot of over-the-counter and pseudo medications out there available that could do more damage than help. But yeah, we really want to make sure we're educating these patients and aware of what they're taking. Make sure everybody's on the same page with what they're taking. As with most of our conditions, there's going to be very specific gerontologic considerations. There's high rates of osteoarthritis that may distract from the RA diagnosis. I want to help polypharmacy as well. Especially when they get older, we get multiple providers and specialists all writing prescriptions. You could get that drug list to be extremely long, and all the different interactions that comes from taking a multitude of medications simultaneously. As they get older, those drug lists, that medication list begins to add up. We get more and more medications they're taking every day. And not only are these drugs interacting, but as they get older, they can also become much more sensitive to these drugs. Also have decreased kidney function and unable to excrete these drugs, leading to toxicity. We really want to be aware of everything that patient's taking. We want to have very accurate med recs, and we want to help them to remove any drugs that are unnecessary or could be duplicates. And we'll finish up this module with gout. It wasn't just for Henry VIII. Gout is a form of arthritis characterized by the buildup of uric acid crystals depositing within the joints. And as these crystals deposit, they can cause the joint to swell up and become extremely painful. These painful flare-ups can last from days to weeks, and then have periods of remission in between. There are over 9 million cases of gout within the U.S., usually within men between the ages of 30 to 50, though sometimes with women, though rarely before menopause. Uric acid is the end byproduct of purine coming from the diet, and normally it's excreted by the kidneys. In the case of gout, the kidneys can't excrete enough of the purine or uric acid, and that uric acid then begins to build up within the joints. It can be caused by a wide array of factors, everything from metabolic syndrome, excessive alcohol, prolonged fasting, and an increased intake of high purine foods such as red meats, shellfish, organ meats can all be common culprits very high in purine. It typically occurs in one or more joints, though usually less than 4. Most common in the big toe. Other areas include the wrists, knees, ankles, or other parts of the foot. And again, very, very painful as these joints swell up from the uric acid crystals. Symptoms typically manifest at night with a sudden swelling and severe pain, even sensitive to even light touch and possibly even a low-grade fever. They have a typical duration of 2 to 10 days with or without treatment before the affected joint can return to normal. Chronic gout is typically multiple joints are involved. Tophi are visible deposits of crystals in that subcutaneous tissue, meaning you'll see those nodules, much like the Heberden and Bouchard nodes we talked about earlier. Here on figure 69.6, we have a picture of those gout flare-up and affecting all those joints within the hand. Severe gout is variable. It may involve infrequent, mild attacks or multiple severe episodes, up to 12 a year, with slow, progressive disability. High serum uric acid causes an increase in these episodes. That chronic inflammation leads to joint deformity, cartilage destruction, and secondary osteoarthritis. The large crystals may even pierce the skin, draining the sinuses and causing infection. Normal uric acid levels typically range from between 2.7 to 8.5. And while that acid levels, they may not indicate current gout, as the serum values may be normal during an acute gout attack after the crystals have built up. Typically, the provider is going to order a 24-hour urine for that uric acid to determine the cause of the gout. And if you remember how a 24-hour urine is collected, you would have the patient void, so if they're starting with an empty bladder, and then start the clock right there. And then every time they void for 24 hours, it's collected in a big jug. The goal is to end the acute attack with an anti-inflammatory agent. Other drug therapies are oral colchicine, an anti-inflammatory, and pain relief in 12 hours, because pain is going to be a very major consideration when we're dealing with that very painful swollen joint. Another possible treatment would be corticosteroids to help deal with that inflammation. Prevention is the priority. For that, we've got drugs such as allopurinol used as that first choice to help lower that uric acid level before the crystals have a chance to develop. We want to monitor those serum uric acid levels regularly, anytime gout's even suspected as a possibility. We also want to make sure we're educating the patient on their dietary restrictions, limiting alcohol, limiting those foods high in purine, no red meats, no shellfish, no organ meats. And also we're maintaining adequate hydration, urine volume to excrete the uric acid, and strategies for weight reduction. Anyway, that's all I've got for you in this slide. I'll see you next in part 2.